Thank you for choosing Axxess On Demand. Axxess believes in continuing education, and we create content to empower you to learn and grow anytime, anywhere. Let's get started.
This is Carol Javins from Axxess, and thank you for joining our training today on the admission assessment and development of the plan of care. So when you are going to be admitting a patient, the patient will be in a pending status. Once they're a referral, they go to pending admission. So you will find the patients by going to the patient chart in the status of pending. Today we have an assessment scheduled for Barry Axxessian. Which assessment you start with depends on your company policy. At Axxess, we have the ability to schedule the initial comprehensive assessment for the RN, which meets criteria under the COPs for both the initial assessment and the nursing comprehensive assessment. This assessment will change your patient's status to active, it will create the initial plan of care, and it will also contain all HIS questions. If your agency chooses to do the brief initial assessment as your initial entry into care, it will change the patient's status to active and it will create the initial plan of care. However, the HIS measures will be inside the comprehensive assessment, which needs to be done separately. When you open your initial comprehensive assessment, the question you will be asked is this here: if the patient is in pending status, would you like to admit the patient? Put in the date that you are changing the patient's status, that you are admitting them in this area here. This will be recorded in the record as the admission date and the first day of the benefit period. Always verify that the date is the same as the assessment that you are assigned, which is right up here in the upper right-hand side. Then select Yes, Admit Patient, and the patient will be in active status. The initial comprehensive assessment is one of our only tabbed documents. The other one that is tabbed in this way, the other ones are our admission documents, the initial assessment and the comprehensive assessment. All of our clinical documents have visit information at the top, where you will put your visit time in and your visit time out. Your travel time in and travel time out is based on your travel time to the patient's home or location of care from where you were at before. Your documentation time in minutes is any documentation that you do outside of the patient visit. If you complete all of your patient documentation either at the bedside or before you drive to your next patient, you would not include any documentation time in this section, as that is all considered part of your visit time. Any documentation you do at home or at the office at a different time would go here in the documentation time in minutes. Associated mileage for driving to the patient is listed here, and surcharge is if there's any tolls or parking or any other fees associated with your visit. You will see up here that the visit is auto-saving. Axxess is 100% cloud-based, web-based solution. So even if your software is always going to be saving, even if your device runs out of power. You will not lose everything that you've put in. You also see here that you cannot change the visit date. It is grayed out. If you need to change the visit date in here, which will flow to the claim and to your payroll, you have to change the visit date in the schedule. Once you change the visit date on the patient or employee schedule, it will then transfer over to the visit information inside. Blue buttons inside Axxess Hospice will do a variety of things. Some of them will take you to different parts of the patient chart. For example, if I select this that says Edit Patient Info, it will take me to the demographics section of the patient chart, where I can make any changes on our single source of truth. So if I want to change any of this demographic information, I would click this button that says Edit Patient Info. So I would go back to the patient's chart to edit their demographic information there so that it will be consistent across claims and the HIS and all clinical documents. The sage green color and the badges in front of these tags right here are HIS questions. HIS questions are required to be completed while you're completing your initial comprehensive assessment. Inside of any of the HIS questions, when we have these tooltips, which is the white eye and the blue background, it will have direct data from the HIS manual on how to code the HIS questions according to directions from CMS. When you scan down the side of the tabs, you will see that some of these tabs will have badges that show up, the black background with the white numbers and letters. That is letting you know that the HIS questions are inside of those tabs. In all nursing documents, you will have the vital signs and additional measurements that looks exactly like this, where you will document your vital signs. And if you select this blue button, it will expand the document, which is one of the other features that blue buttons will do in clinical documents, besides taking you to another part of the chart. So inside the additional measurements is eligibility information that will flow to your patient's plan of care and IDG summary. Inside of the tooltip for the BMI, we'll take you to a BMI calculator in a different tab. So I said this patient was 102 pounds and 5'6". This patient's BMI is 16.5. Inside the tooltips for the FAST is going to give you more detail about the different FAST stages in case you have a new nurse that isn't as familiar with the FAST scale. The same with the New York Heart Association tooltip, the PPS tooltip, and the KPS tooltip. This will help with training your new staff. How often you do this is based on your company policy. It can be done as often as every visit or as limited amount as your agency decides. If I want to add more diagnoses to my patient's record to have it flow to the assessment, I would click the button here and it will bring me to the diagnosis and clinical information page in the patient chart. Inside all of our nursing documents is an imminence of death assessment. This is generally near the top of any of our assessments so that your staff is alerted when they go out immediately if this patient might be showing signs of imminence, and to be able to adjust their care based on that assessment, including calling in other team members and starting extra visits that helps you capture your SIA rate. The death note is in every document in the imminence of death section. So if your patient dies during the visit, you can select this button and a death note will open in the patient's chart and be scheduled to you for that day. At the bottom of most of the sections in the initial comprehensive assessment are these purple sections where you'll be able to add your plan of care, problems, goals, and interventions. And we'll do a couple of those while we're doing our assessment. Any place where you see round buttons is a single select, so you cannot select both of the answers. If you need to update the patient's code status or add the funeral home at any point in any visit, the Advanced Directives button is present in the nursing documents as well as your social worker documents and your spiritual counselor documents. Selecting or unselecting this button for Do Not Resuscitate will select the badge that shows on the patient's chart that alerts you if this patient is a full code or not. And at the bottom of this Advanced Directives tab in the patient chart is the funeral home information. Anytime you see a colon at the end of a statement in Axxess Hospice, that means if you make that selection, you will see more options underneath. You can also see when I open this that I have all of these square boxes that I can make selections. The square boxes are multi-select. And here is your spiritual HISS question. And your initial spiritual assessment. In the Supportive Assistance tab, you'll see the initial psychosocial assessment that meets the criteria for addressing all of the potential areas on an initial assessment that might be the immediate need. If you need to update the patient's emergency preparedness after you've been to the house and seen them, this button here will take you to that section in the patient chart. And if you see on your first assessment that bereavement needs are the immediate need for your patient and family, you can open a bereavement risk assessment using this button here. If your accrediting body is ACHC, this is a required thing to do on the first nursing assessment, and then you can do it again by the spiritual counselor or social worker or bereavement coordinator at a later time. We will address this bereavement assessment in an additional training. Hours of sleep per day will also flow to the IDG summary as a sign of decline in eligibility. If at any time in a section you see no problems identified and you select it, it will close all of the selections below. As I said, this patient has Parkinson's disease. I am going to open up a neurologic status plan of care so I can explain to you how to develop your plan of care problems, goals, and interventions. Inside your plans of care, when you see the tooltips, we've given some hints again to help your newer nurses with building a plan of care. So we have different options for things that they might want to put in when they're making their problem statement. So I'm going to say my Parkinson's patient has some chronic confusion. Everything inside the problem statements, goals, and interventions is 100% editable. So you can make this as specific to your patient as you want. Your goal length is based on the type of goal you have in the patient's situation. So this safety needs met goal, for example, is a long-term goal. It's that we will have the ADL safety and activity needs met ongoing. So I'm going to choose ongoing. Let's say I also, with this chronically confused patient, want to do some teaching for the caregiver so they can understand the disease progression, and I'm going to do a lot of teaching to help them with that. This might be a 30-day goal, where I'm going to do a lot of intensive training in the first 30 days. At any time during your revision of the plan of care during the patient's stay, you can adjust your goal length. Anytime that you are in a care plan where you see that you have asterisks, you do need to remove those asterisks to put in specific patient information. And when you assign an intervention to someone, you will pick from multidisciplinary choices. Because as you know, in hospice, we have people who will work on the same goal and even the same interventions from different disciplines. So I'm going to say that the nurse is going to give this medication, and so is the caregiver. I'm not going to assign the social worker to give medications. Also, any of these tags out here, when you see them, will not be visible on the plan of care. Only the text inside of this box will be printed on the plan of care. So talking to the daughter about preferences for ADL and activities, the nurse will do that. Probably the social worker will do that. And the aide will probably do that if they're going to have an aide when they come out to do visits. In this agitation intervention, I'm going to have everyone do that. If the patient is agitated, we'll do some diversion and some calming activities. For every problem statement, you need to select at least one goal and at least one intervention. You can have more than one goal, you can have more than one intervention, and you can have more than one problem statement in any area. We're going to skip ahead to the pain section to show you the pain HISS assessment. Remember, anytime you see this sage green color with the badge, this is a HISS question. And when you see an item with a colon, it will expand to have more information inside. If you say a patient can communicate pain, use the yes or no selections in any pain assessment inside any nursing document. And if the patient is unable to verbally communicate their pain to you, you can choose based on your company policy to use the Wong-Baker, which is our FACES scale, or the pain AD. When you see a table where the items light up with color, that means that this is totaling up a score for you at the bottom. So this patient, we're going to say had mild pain using the pain AD. And if I say pain is an active problem for the patient, it's going to ask me if I did a comprehensive pain assessment. And here's all the parts of the comprehensive assessment. When you see this drop down and you select an item and the drop down stays, this is a multi-select option. So if I select all of the options that I feel are appropriate, and if I select one accidentally, I can just select the X and it will go away. And then I'll answer my HIS questions of all of the ones that I addressed. I'm saying this patient has pain, so I'm going to put a pain care plan in here as well. I'm going to say we're going to decrease any pain behaviors because we use the nonverbal. And I'm going to say I'm going to teach her about these pain behaviors. And I'd like her to have that in 15 days. Maybe we'll go with 5 days. Inside some of your plan of care goals, you'll see CC and GIP goals. You can see in here is that this is a way to document your plan of care changes to the higher level of care. That includes that you're going to be doing symptom management as well as discharge planning for the patient to return to a routine home care level of care. And when you see other, it is completely blank inside, and you can use templates if your agency has written templates for you to be able to put in specific language. And I'm going to have everyone who comes out to the house check and see if the patient has pain, because we all do that when we visit our patients. And again, you see the asterisks are here, so you do need to remove that. And I'm going to say the nurse and the caregiver will be administering the medication. Nope. You will also see in the pain care plan that we have the ability to put in interventions if we see that there's a risk of drug diversion. We also have the ability to put in some high tech of our IV site care, IV infusion, palliative radiation, or chemotherapy. And we're going to teach everyone how to do non-pharmacologic methods of pain management. We'll go to the respiratory section next because we do have some HIS questions there, and the assessment will not allow me to close it without completing all HIS questions. You will see here that in all of our respiratory sections and all of our nursing notes, we do have an extensive oxygen safety risk assessment. We're going to say this patient was assessed for screened for shortness of breath. And when I say yes, more information is in here. If I say yes that we started treatment, it would go in here. We're going to say this patient did not have shortness of breath though. If you have a patient on oxygen, please see the alteration in respiratory status problem area where you do have the ability to document your oxygen safety education care plan, teaching of all oxygen safety measures, and evaluating compliance, as well as the ability to document that you're working on a safety contract for your patients who may be non-compliant with oxygen safety. But this is a very important plan of care for many of your surveying bodies. Let's skip over to functional here. If you need to start an incident report, you can do the incident report from this button right here, which we will review in another training. Your fall risk assessment will also flow to the IDG summary. You can do that as often as your company compliance says. If you have a patient who's going to have a hospice aid and you want to make sure that the hospice aid is included on your comprehensive plan of care and not just on your aid assignment, that would be inside your functional status plan of care. So I'm going to put this on here because we are going to have an aid for Barry. And we're going to give him a goal of safe ADL care ongoing. And on this intervention, we'll say that we're going to give them a hospice aid. Also, if I decide I need a PT or OT evaluation, I can put that in the functional status plan of care as well. In the integumentary section is where you'll document Braden scale as well as wound measurements. I'll show you the Braden scale first. This also will flow to your IDG summary. So you'll be able to track decline in their skin risk or improvement in their skin risk if you need to make changes to your plan of care. If you have wounds, select Wound Worksheet and it will open a section below where you can add your wound documentation. There are a lot of very detailed tooltips in here about wound measurement and assessment to try and help your nurses be consistent with everyone measuring the same way. We have definitions of the different ulcers, so you can determine between them. If you need to add measurements for additional wounds, once you've completed one wound measurement, you have the option to add another wound. You can add up to 20 wounds in your documents. If you are going to put in any wound care orders, please put them in on your plan of care. If you put the wound care orders in your other order section of your physician order document, which we will go over briefly today and more at our next clinical training, no one will see the wound care treatments unless it is on the plan of care. So we're going to say why this patient has impaired skin integrity. And my goal, well, I'd like it to heal to maximum potential. It's a skin tear. It might. So we'll see. We can try. To also have some of our more standard hospice for chronic wounds that the wound won't have infection, that will manage pain, odor, and drainage of the wound. I'm going to give that we'll have no signs of infection too. And that you're going to teach the caregiver, or that you'll teach and they will demonstrate effective wound care. So I said I didn't want to have any signs of infection, so I'm going to educate about signs of infection. I'm going to have wound measurement at least weekly. And I'm going to do that as the nurse. And then we have the different treatments that you can put in. For the skin tear here, I'm going to say this is just plain old wound care. So I'm going to put wound care on left forearm. I'm going to cleanse and irrigate it with wound cleanser. I'm going to apply, I'm just going to put a Tegaderm on it. And then I'm not securing my Tegaderm with anything, so I can just remove this part. And I have in there that I'm going to teach the family to do it, but with the Tegaderm, I'm probably just going to keep that on until my next visit. But I also have things like rash treatment, cotton gloves, G-tube care, surgical drain care, IV site care, suture and staple removal. So lots of different types of wounds that you can put your treatment in here. I do have in the nutritional health screening that we will have that in the nutritional section. You'll also have quite an extensive nutritional care plan selection, since that is something for a variety of reasons that comes up with our hospice patients. So please take time to review all of our different problem statements, goals, and interventions that we have for all of our problem areas, so that we tried to be very, very thorough on these, but you always have the option of other and having templates. In the medication section, you'll see there's a lot of things in here that are important. We've got our scheduled opioid, PRN, opioid and bowel regimen section. I do have a button to add an allergy. I'm going to go ahead and put my allergy in right now. If I put in an active allergy, I have all of these fields that are required. If I want to say the patient has no known allergies, I can select that and it will put no known allergies on my patient's profile as well. I'm going to say my patient has an allergy to latex. And I'm going to save that allergy here. So this is now on the allergy profile. If I want to ever deactivate the allergy, you know how you go do an admission sometimes and they give you this allergy list of 40 different things, or 4, or some number between 4 and 40 is usually correct. And then when you actually do more information, you find out that the patient isn't actually allergic to all of those things. You can go in and deactivate the allergy and put in an end date. and it will move to the inactive allergy section. So we're going to go back here to this section of medication assessment. Now, this section of medication assessment is in all of your nursing documents. Please pay special attention to this medication issues identified. Medication review was in the top 10 tags recently, and it was about specifically looking for duplicate therapy, laboratory monitoring, ineffective drug therapy, and drug interactions. So until you get familiar with what's in there, you should open that on every visit just to make sure that you are not missing anything. And if you have an IV or sub-Q access, you can document the status of your site here. To enter the medications for the patient, you're going to select the button Review Medication Profile. That is going to open the patient's medication profile, where we will now add medications. So whenever you see Update on a section, a button that says Update Medications, Update Frequencies, Update Diagnosis, any Update Plan of Care, that means what you're doing is going to need to be attached to a physician order. So when you select that, if you do not have any physician orders assigned to you for that patient already open, because maybe you started one earlier in your visit and you're making a change to medications and frequencies and plan of care, and they're all on one order, you might have an order open. If you're just starting to make your order changes, generally you will see that there's no open orders and you will create an order. So it's going to allow me to select the date in case I'm documenting late. And I can't remember who this patient's doctor is, so I'm going to pick Show Details. And it's going to open all of the things up here, including their terminal diagnosis that's been selected, their admission date and benefit period, and the patient's attending physician. So I can always see that information by selecting Show Details at the top of my clinical documents. When I've created an order and I'm inside the order in the section of the chart that needs to be changed only through a physician order, I will see this purple stripe at the top of the section I'm trying to change. That is showing me that all of the updates will be going to the doctor's order dated on this day. And now instead of Update Medication, I have a button that says Add Medication, and I also have the ability to discontinue once I have medications in. So I'm going to add some medications for this patient. I said that he's taking acetaminophen, 500. I probably should spell it correctly. That will make it a lot easier. So when I put in acetaminophen 500, I'll be able to pick from what types I have. Now, if you cannot find a medication with one name that you're looking for, try using the generic name or try changing the order of a combination product. For example, if I'm trying to put in hydrocodone, I'm seeing all of these things here that have hydrocodone in it. And so let's say I just want to say hydrocodone slash acetaminophen. This is certainly not giving me the options that I'm looking for. Again, I misspelled it. It's not recognizing, but it's still not giving me options of what I'm looking for. However, hydrocodone by itself without the slash, if I scroll down, you'll see I have some options that include acetaminophen dash hydrocodone. So if I try to put in hydrocodone slash acetaminophen, it will not recognize that. So when you're getting used to the medication profile that we use, our medication database, please learn by playing around and putting in different options how the medications are listed in the database. This patient is on acetaminophen. 500. Say it's a tablet. We're going to start it today. All red asterisks in any field are required fields. And then I'm going to select who can administer the medication and if the medication is covered under the hospice benefit. Then I can save the medication and add another, and it opens the profile again where I can add more medications. So I said this patient was on Cinemet. $25,100. And this will be given by the caregiver and the hospice. I'm going to save and add another. Let's add some quetiapine, some Seroquel, PRN for this guy in case he gets agitated. So now I've added these 3 medications and they all show here as an active medication. If you hover over the miscellaneous analgesics will show up. This little RX piece of paper here is showing you your drug classification. You'll have a column for the indication as well as the start date, and if the medication is discontinued, there'll be a discontinue date. And you'll be able to see who is the doctor who made the medication changes. You'll also see that this drug interaction is being listed. The drug interaction is being done automatically for every medication that is added or discontinued. If you want to see what the drug interactions are, you can look here at the detailed drug interaction report. So we see there's a reaction between Cinemet and quetiapine. If you want to print the medication interaction report, you can select that and then it will go into your download folder where you can open and view and print for your patient and family. You can see by the badges here that all of the medications have a little green check mark next to hospice. That means that the hospice is covering those medications. If I wanted to print the medication profile, I could select that, and again in my download folder on my computer, the PDF view of the medication profile will be available for me to print for my patient or family. And it will show all of the medications, current and discontinued. Based on your company policy, you will be asked to sign the medication profile either at all med changes or at admissions and recertifications, potentially at IDG. Do check with your administration on how often you should be signing your medication profile. To sign the medication profile, you'll select this button here that says Sign Medication Profile. And it will open up your medication profile, which is also able to be printed and reviewed. You will see all of the active medications. You'll see the drug interactions. You'll see active allergies. And then you will have the ability to sign an attestation that you've reviewed all the medications for all the significant interactions and reviewed significant findings with the physician. And then you will select the date and sign the medication profile. So all copies of prior signed medication profiles will be stored in the Sign Medication Profile tab for you to be able to download and print. It'll also show you what the medications were when each person signed it. The orders tab is so that you'll be able to see if maybe it's your patient, you're on vacation for a couple weeks, and you come back and see that someone made changes on your patient's meds. You can go to this orders tab and see who it was that made the changes. So now that I'm done entering the medications, I'm going to close out and come in and answer my medication HIS questions. I did not actually schedule an opioid, and I did not continue with a PRN or order a new PRN. Finally, we come to the summary tab. Much of the information here is purple, so purple means that it's related to the plan of care. So we have your order for admission is right here where you do have the asterisks for what is the diagnosis for the patient. You have the documentation of physician contact. You're going to say the hospice physician is going to be the attending and sign the death certificate. Here's where I can document the verbal certification being received. It's best practice to try and receive that verbal certification on your initial assessment. However, you do have 48 hours to be able to get the verbal CTI. Generally speaking, you are calling the doctor when you're doing your admission assessment, at least the hospice physician, and generally both physicians if their hospice physician is not the attending. It is important to have this documented within the 48 hours of start of care, because you do need to have this documented in order for your billing team to send in your NOE, or your Notice of Election, to Medicare. If you do not get the verbal certification on the same day, please document that you received your verbal certification of terminal illness from the physician on a care coordination note, and please let your biller know where to locate that information so they can verify it prior to submitting the claim. Here's where I would put my diet. And my activity level. Your diet, activity, and level of care changes of orders will be on your physician order form, which we will look at a little bit. But any changes of those, this is the start of the order. The changes will be on the physician order form. In all of our nursing documents, we also have an assessment for a higher level of care. In our routine and PRN visit note, it is right next to the imminence of death assessment at the top of the documents, so that your attention is drawn there immediately. Here it's at the end of your assessment on your first visit. If the patient does need a higher level of care and you say yes, you'll document if it's GIP or continuous, and when you open it, because see there's the colons, you'll be able to document what specific symptom. These are the ones that Medicare specifically mentions for continuous care and GIP, but you do have the option for other. And you also can see it's multi-select, so you can have multiple symptoms that you are having a patient on a higher level of care for. And in the documentation section here, the tooltip is reminding you of the types of things your surveying bodies is looking for a patient on a higher level of care. So they're going to want to see what specifically is the symptom, what did you try that did not work, what was the response to treatment, and why can't we do this treatment at a lower level of care. So this is all things that's listed by our surveying bodies and by the investigators that have been looking into fraud on GIP and continuous care. So we have a lot of hints in here to help you with making sure that you're crossing all your T's and dotting all of your I's for your higher level of care. I'm going to say this patient doesn't need a higher level of care, but I wanted to show you that. Now we're going to enter our visit frequencies for this patient. So I'm going to select the frequency button, and it's going to take me to the patient's visit frequency profile. Now you can see I have my benefit period here, and I can choose to look at my frequencies by only specific disciplines. I like to use all, but you can look only for yours. And then I have the button that says Update Frequencies. Remember that anytime you see a button that says Update, that means it needs to be attached to a physician's order to make the change. So I'm going to select Update Frequencies, and it's going to tell me I have an order already open. Remember, I have this order from when I was putting in the patient's medications. So I'm going to say Select Order. And I see that purple stripe I was talking about. When you see the purple stripe, you know you are inside the physician's order and can make changes. And now instead of update frequency, it says add visit frequency. I'm going to select that. And it's going to give me all this information about how to put in a visit frequency. So the frequency formats are usually one number, one letter, and one number. You also can use a range for some of your frequencies, except for hospice aides, homemakers, and volunteers. So you can say 1 to 2, 1-2, week 2. The first number is how many times. The letter is how many times in what time period. For example, W, if you open this tooltip, is weekly. So if you say 3W1 means 3 visits a week for 1 week. 1M3 means 1 visit per month for 3 months. You can put ranges for the frequency, but not for the duration. So you can, it's acceptable to say 1-2 week 5 and not 1-2 week 4 to 5. They're saying this is not a valid frequency. The week is set by your agency. Most agencies do Sunday through Saturday, but some do start their Medicare week on Saturday through Friday. Please check with your company during training to make sure you know what their Medicare week is, because your Medicare week is going to be the first day of your Medicare week is the first day of your visit week. So if my Medicare week is Sunday through Saturday, my Medicare week right now, even though it's Friday, it will end on Saturday. So if I want to see this patient 3 times a week generally, I'm not going to want to start that 3 times a week here because I'm not going to see that patient 3 times between Friday and Saturday. If you have a monthly visit order, it counts 30 days, not the calendar month, but it will do a frequency for 30 days. So if I put in a visit frequency for a social worker twice a month for 3 months, and I start it on the 29th, it's going to count 30 days from the 29th. It will not say the month is done on the 30th. So please check with your company about what your visit week is. For your weekly visits, which are generally your nursing and your hospice aides, but sometimes your social workers and chaplains also have weekly frequencies as well. So I'm going to say this is my nursing frequency, and I'm going to start it today. So this week I'm only going to see the patient once, we'll say. So I'm going to say 1 week 1. And then I'm going to count the weeks. My benefit period ends on 9/23. So how many weeks do I have in this benefit period? So this is week 1 right here. So then my next visit frequency is I'm going to do twice a week for how many weeks? So 1 week, 2, 3, 4, 5, 6, 7, 8, 9, 10 weeks gets me until the beginning of September, 11, 12, 13 weeks. I've got Wednesday here. So I'm going to say 2 times a week for 13 weeks. I could also say 1 to 2. Depending on your company policy. I'm going to start this visit frequency today. And this is not a PRN order. We're going to do our PRN next. So count your weeks and know when your Medicare week starts. So to make sure that you're not writing an order that it's going to not be possible to be compliant with. If you're doing daily visits, for example, and you write your order as 7 times a week, and you write that on Tuesday, you really only have 5 days to do those 7 visits. So please pay attention to where you are in your Medicare week when you write your visit frequency order. So I'm going to save and add another. Now I'm going to put in my nursing PRN order. So I type in skilled nurse. You can put your PRN orders in a variety of ways. You can put in a monthly PRN, like maybe you want 2 month 3, because it's a 90-day benefit period so for your PRN, and that's fine. You can put in a weekly PRN, like 1 week 14, and then say PRN. I like to put in just a number. If I say a number, that's going to get me through the entire benefit period. So I have 4 PRNs for the entire benefit period. Any of those formats are acceptable for PRN orders. I'm going to start my PRN order today, and I'm going to mark PRN yes. So why am I going to do PRN visits for a patient as a nurse? Well, I will probably do it for symptom management and assessment of needs. You will in your PRN visits. There is a place to document why you did that specific PRN visit, but it is required when you put in a PRN order that you say why you would do a PRN visit. I am now going to add an assessment for my medical social worker, MSW, and our solution means medical social worker, not master's. And my social worker, I'm going to put in an order for her to come out and see the patient for the initial assessment. And I don't think she's coming out today or tomorrow. So I don't want to write that 1 week 1 starting today, because that means she has to come out today or tomorrow. I'm going to say starting on Sunday is when that week starts. She has until Tuesday to complete her initial assessment, her comprehensive assessment for social work. So I'm going to give that order for her so she has an order to start. Most of the agencies have chosen to have their nurse put that initial order in. Then we'll save and add another. We're going to do that for the chaplain as well. The chaplains are called spiritual counselors in the Axxess solution. I'm also going to put in my 1 week 1 that's going to start on Sunday. You can see down here, I can see all the frequencies I have put in already. So I've got my nursing by the week, my social worker, and my spiritual counselor. I would like to add my hospice aide. There we go. So my hospice aide, I'm going to have come out on Mondays and Thursdays, let's say. So I will not have an aide visit start this day, but I'll have it start on Sunday. And we're going to do 2 times a week, times 12 weeks, and 1 time a week for 1 week. Because if you remember, when we looked at that last week in September, the benefit period ends on Wednesday. So if I have my patient being seen on Mondays and Thursdays, this last week will only be 1 time a week. So I will have this start on Sunday, and I will save my frequency. So now you'll see I have all of my frequencies in here with an end date and a start date for each frequency. If I'm going to discontinue any frequencies, I do need to make sure I discontinue it after it starts. I cannot discontinue date prior to the start date of an order. But we'll go over discontinuing frequencies and adjusting those in our next clinical documentation for routine visits. You can see here for your PRN that if I hover over this little text bubble, it will tell me the reason that I have a PRN order. And as we schedule out this patient's visits, you will be able to see all of the visits associated with the patient's orders, which we will review in our the next clinical documentation training. So I'm going to close this tab now as I'm done putting in the frequencies. Now I'm going to put in my supplies and DME. Again, you see update button, which means it does require attachment to a physician order. So to add and update your DME and supplies, you'll select the button and again attach to the physician's order that you already have open. This is always important when you have a physician order open to put all of the orders on one order form so that your physician is not having to sign multiple documents for one visit and that your office staff does not have to track the progress of multiple physician orders. So you'll select order. And again, you'll see I have my purple stripe, which means I can make the changes. So to add DME, these DME and supplies for that matter will all come from your agency DME and supply list that was set up by your administrative staff. If there is a DME or supply that you do not see, it's because it's not on the list by your administrative staff, so please contact your leadership to have the DME and supply added or to discuss why you need it for your patient. I do have type ahead, so it'll start to pull up anything that's on my DME list or my supply list that has the letters. So if I just have W, you see I have everything with the W. And as I add more items, more letters, it will select more choices for me. I will put a start date and then select save. End date is only for when you are going to discontinue that piece of DME. I'm going to get him a hospital bed too. And I'll say save. Your DME and supplies will flow to the patient's plan of care from this part of their patient profile. And then I must select save on this page to make sure the changes I put in the DME and supplies are going to save. When I select save, it is bringing me back to the physician order, which you guys have not had a chance to see yet. A brief overview before we go back to our assessment is you can see my DME is here, my medications, and my supplies, and my frequencies are all showing up here on this physician order, just like they will when you're not doing an admission and you're making changes to any of these areas. You'll also have the ability to put changes in your diagnoses, to make your level of care changes, your activity changes, and your diet changes throughout your care. If you're changing the patient's diagnosis, it also requires to go through a physician order. If I came to this straight from the patient profile and selected update diagnosis, it would ask me to select which physician order or open a physician order to get my purple stripe. When I come to an area that needs to be changed from a physician order from the physician order, it is in editable format. So when I select add diagnosis, you can either put in a code if you know it, or you can do searches by name. So I'm going to say that we've got some dysphagia. If you know the full code, you can put it in. If you do not, follow your company policies. The start date needs to be if you want it on your claim, your notice of election claim, it needs to be on the day of admission or before. It cannot be after. For documenting relatedness of diagnosis, it is not required to document relatedness by the solution, because many agencies might do this in different ways. If you say yes, that this is related diagnosis to the terminal prognosis, you say add, and there it is, and you'll know, and then you know that you're also covering and care planning anything related to the dysphagia, because you and your physician in discussion have determined that this is a related diagnosis. However, if you say something like hypothyroid, which I don't know about you guys, but in the 20-something years I've done hospice, the only time I've seen hypothyroid related is if it's thyroid cancer. So now I put in hypothyroidism. If I say no, it is going to make me document specifically the rationale and medical management information as to why this is not related to the terminal prognosis. Now, many clinicians are not comfortable putting that information in, and with the fiscal year 2021 that's starting in October 1st, where they're going to, your patients and their responsible parties are going to be able to ask for this information on reasons why things are related and unrelated, covered and non-covered. They're going to be looking for what the physician determines why the diagnosis is not related to the terminal diagnosis or terminal prognosis or symptom burden related to their decline. So this is usually a physician decision. So you could choose, if you're not sure if this is related or not, or you think it's no, but you don't know what to write, you do not have to say no. You can leave that blank for the physician to document. Maybe he'll document it in his CTI, maybe he'll document it here during IDG, but you do not have to say yes or no. You can leave it blank. Also, if you had Parkinson's disease, say, put in there, and you get out there and realize your patient has CHF and that's what they're actually going to die from, you can change, and you can take another diagnosis that's further down the list and make it the primary diagnosis. And it will move it to the top. You can also resolve a diagnosis. Let's say your patient was admitted with a UTI or aspiration pneumonitis, and it resolves. You can resolve the diagnosis and put in the resolution date, and then that diagnosis will go to the history as opposed to being in the active diagnoses. You can also use these arrows to make a new terminal diagnosis. But we're going to have the Parkinson's be the terminal diagnosis. And now I'm going to select Save on this tab. I've put in my DME, my medications, my supplies, my frequencies. All of these in here. I'm going to keep this open though. I'm not going to complete it yet because I'm not sure if I'm not going to put in a few more orders. Inside the infection surveillance, you have the ability to document symptoms of COVID-19, any infection risk factors. We do have a button to start an infectious disease infection report if you have a patient on an antibiotic or you track symptoms of infection without antibiotic use. And we'll go over that in our next clinical documentation. You also have the ability to document on the infectious disease profile for the patient from the patient chart in the quick links, which is right up here. You'll see infectious diseases there. There's also a button in all of our clinical documents where you can add a COVID-19 screening. Many agencies are documenting this prior to an in-person visit. Do I live in an area where COVID is spreading? I believe I do. And I'll say what date I did the screening. And this will stay in my patient's chart so that I can have tracking and you can see easily what the screening results were. My next section that I want to call attention to is coordination of care. Coordination of care is in every clinical document. Nursing, social workers, chaplains, volunteers, volunteer coordinators, hospice aides, and everything in between. Because coordination of care is the communication we do between our team members, between our patients and staff, between our pharmacies and DMEs and vendors to make sure the patient has a fully comprehensive and coordinated plan of care. So please document who you talk to. I'm going to say on this admission, I talked to a lot of people. If I ordered equipment, I'll say I called the DME company. If I called in drugs, I can say what pharmacy I called. But coordination of care or documentation of coordination of care is always in the top 10 tags. So please make sure you go in there and document some coordination of care on every visit. In your comprehensive assessments, you will also see that there's first visit interventions. This is for your nursing, your social worker, your chaplains. It'll be different first visit interventions based on your discipline, but please make sure on your initial assessment, you go through and review the things that are inside your first visit interventions and check the ones that are appropriate. It's also some good hints for your newer hospice nurses of things that your surveying bodies are going to be looking for when they're looking at your admission documentation to see what training you did. In your plan of care review section, plan of care is often a top 10 tag, usually 5 or 6 of the top 10 tags are related to plan of care in some way. So we have that you established it in collaboration and that you did education and training. Hopefully everybody is agreeing with the plan of care that's in place. If not, you can say they disagree or they asked for changes. And generally after the first visit, they certainly need reinforcement. And then you'll document people's ability to participate in the plan of care and their willingness to participate in the plan of care. If you need to update the patient's authorized contacts, this button is in all of your clinical documents as well, so you can go in and add or move around the authorized contacts that are in the patient's chart. So for example, if you go out and you find out there's another person that you want to add as an authorized contact, you can add them right here. And maybe you find out that second contact is actually supposed to be the primary contact. You can move it up right here and make that person the primary, and this person who's up on the top will be secondary. Notice that you can also document who's the emergency contact, who is the primary bereaved, and who will be receiving the CAP survey. Once you select who will receive the CAP survey, you cannot select that again. That can only be for one contact. So if you want to change who's going to be receiving the CAP survey, please unmark one and mark the other one. Here in my admission narrative is where I will document my narrative. I also have a button here that says Send Note to IDG Summary. This admission narrative will automatically go on your initial plan of care, but it also will go to the IDG Summary as your IDG note if you select this box. The box Send Note to IDG Summary is in different places in your comprehensive assessments where it's under an admission narrative or plan of care assessment in the spiritual counselor and psychosocial comprehensive assessments. And in your regular routine clinical notes and PRN notes, that section is in where you're documenting progress towards your goals for your plan of care, which we will review at our other clinical documentation webinar. But I highly recommend documenting things in this section and selecting this button. the clinical evaluation LCD, I would like to show you our eligibility document. So you may find that your team has put this already on your schedule so that you know to do it, or they may expect that you will click this button and open the LCD document. Now I happen to have put it on this patient's schedule, so I'm going to open the patient schedule using a right click, which will open my patient schedule in a new tab because I want to keep my initial comprehensive assessment open while I open my LCD. So you can see I scheduled myself the clinical evaluation LCD visit. LCDs mean local coverage determination, and we have multiple blogs on the Axxess Hospice site to review how to use the LCDs or the local coverage determinations to document eligibility for your patients. Many agencies will do this on admission and recertification, as well as change in condition, which might mean you're evaluating to see if the patient is still eligible to be on hospice for live discharge, or if you're planning to change the patient's diagnosis potentially. I'm going to say this will probably take me about 10 minutes. But in reality, this will probably take me longer than 10 minutes. This document, the clinical evaluation in LCD, is very helpful for your physicians when they are writing out their CTI, the certification of terminal illness, because if you've completed the clinical evaluation in LCD for your admission and recertification, the doctor can see all of the elements that are required to be documented by the physician in the CTI narrative related to the LCDs and eligibility. So you can see that there are non-disease specific. You can see this dependence in ADLs is able to be documented. When you see people documented, someone is dependent or assistance with 4 out of 6 or 6 out of 6. These are the 6 that people are referring to. And then you're looking for a specific clinical decline in the last 6 months. There is a very long but helpful tooltip about documenting eligibility right here. I highly recommend everyone read this because it comes from a combination of information from NHPCO as well as Medicare. So it talks about things that how you're going to be using the clinical status of the patient to determine the anticipated progression of disease is more than likely than not to be 6 months or less life expectancy. And then you'll have in here other non-disease specific that will help with your physician being able to know what types of declines the patient's having. You can put labs and scans and tests here, PPS and KPS. And then in the section below is disease-specific criteria. Now, you might be admitting a patient who does not have these specific diseases, and that's okay. Follow your company policy. Some companies will say, even if you don't have a primary diagnosis of dementia, fill out the LCD so I have documentation of all your comorbidities on here. But some will say not. The most important things are that you've done the non-disease specific about the ADLs, burden of illness, clinical decline. And then if you have one of the diseases that is listed here by the MACs, you can pick it and open it up. So this patient that we did is for Parkinson's disease, which isn't one of the diagnoses that there is a specific LCD for. I've had patients who we did a dementia and related disorder. I've also had ones that we looked at the stroke criteria because both of them being end-stage neurologic diseases. It's good to see like what type of complications from their end-stage neurologic disease might be listed. So if the patient has aspiration pneumonia, fever, pyelonephritis, stage 3, 4 decubes, losing weight, see that there's a colon there, so remember, You can open it up and there's going to be more information in there. And then looking for a KPS or PPS of 40% or less. So open these up and get to know them, see what's inside all of this information, and talk to your clinical supervisor about how often they want you to be doing this. Now, since I do recommend that the physicians review the LCD visit when they're doing their CTI, I recommend that you have a very detailed admission narrative in your clinical evaluation LCD visit. Now, one thing that I really dislike is double documenting. So if I'm going to write an extensive detailed clinical documentation for eligibility here, I would like to not have the same thing typed twice. So what I do is I copy and paste that so I don't have to do it twice. Please talk to your company how they would want you to do that, if they want you to have the same thing in both, or what they would like. And then I'm going to complete my LCD document. When I complete a document, I will hit complete, and it will check to make sure all of my required fields are done. And then it will verify, and then I will select complete. I'm not picking the date. It is going to attach the date that I actually signed the clinical document. So please try to be timely with your documentation, because the actual date you sign it will be attached. And then I'm going to close this tab. I have some additional plans of care here that I would like you to get familiar with. We have an admission plan of care, which is a workflow to make sure that you're meeting all of the tasks required in the first 5 days of assessment for the patient. You also have a plan of care for change in level of care so that you're documenting both symptom management and coordination of care between the types of coordination, the levels of care. So it has things in here making sure that you have planned who's going to do the evaluation, who's going to get the ambulance, did someone call report. As some of you know, sometimes steps get missed, and it can cause quite a bit of problem when you're changing patients from one location to another. We also have a facility coordination plan of care for any of your patients that happen to be living in a facility. So you can document this. Facility coordination is always looked at by the surveyors at both the facilities and the hospices. And we also have a need for infection management. So once I've completed my assessment and I've done my clinical evaluation LCD based on the information that I've gathered here, I can either select check errors or I can select complete. Either way, it's going to check for errors. So I'm going to select complete. And it's telling me my only error at this point is that I didn't put in a visit timeout. Well, that's good. I don't want it to close without a visit timeout. Even though there are times that drop in that are by 15 minutes, you can put whatever time you would like to have in there. Now let's do an error check again. So it's looking now at my HIS questions. And it's saying that I have a bad Medicare number, that is not in the right format. I can believe that that is true. I'm going to get a different Medicare number. So on a real patient, you will probably not get that Medicare error. On our test patients, sometimes we don't make the best pretend Medicare number. So now that I've updated the Medicare number, I see that I have an inconsistency. So an inconsistency is not something that will get my HIS hospice information set rejected, but it will potentially be a quality measure. It will not stop you from completing the assessment if you put in data that potentially is not going to be best practice. So here what it's saying is that when I answered this question, it's saying that I did not ask their preference about hospitalization. Here's the question. It's saying I said no. Maybe that's true. Maybe I didn't ask. But before I complete my assessment, it's going to ask me if I really want to leave the house without having answered that question. Now I can check again. And it's saying, one moment, didn't want to save that for me. Now we're going to check for errors. And it's saying that if I ask this question, I have to put the date in. Now I'll check again. And it's telling me that I have no errors. Everything has been verified. And I can click to complete. Again, this will attach the date that I signed it. So please try to be timely. And now you can see that my patient has a level of care that was inside of my document. I'm going to go into that physician order that I opened to make sure that all of the orders are completed. I've done all of the orders that I need for the patient. I've put in the medications, supplies, my problems, goals, interventions. I'm going to say I read those orders back and verified, and I'm going to complete my order. Then I will complete my order. When I look at my list view, I can see that these documents are submitted with signature. The status of submitted with signature means that you have completed the document and it has gone to the QA center for review from your management or leadership team. Once the orders and assessments are reviewed and approved in QA, they will have a completed status. Now, I also wanted to show you the hospice physician certification of terminal illness. This is not going to be completed by you on the admission. This is a document that is part of the admission process that the physician is going to be completing. But I wanted to show you what's inside because many of my hospice team members work to help the doctor with setting up the CTI prior to sending it to him to sign. So for example, they will open which benefit period it is for the doctor and then mark the benefit period, because if the benefit period is not marked or it's marked incorrectly, that is going to be a technical denial. Your agency can, your MAC, your Medicare Administrative Contractor, can decide to not pay your hospice agency for the whole benefit period if they pick the wrong benefit period in the CTI. So a lot of agencies will pick that for the doctor and mark down that the doctor did the documentation. This physician narrative, according to MACs and Medicare, has to be completed by the physician. It cannot have check boxes or specific language. It has to be narrative and refer to the LCDs and prognostic indicators and your scales. And it should include all of the diagnoses that contribute to the terminal prognosis and have all of these specific clinical findings like signs, symptoms, labs, weights, measurements, oral intake. So this is why it's good to have the documentation for the physician in the LCD document so that he has it to refer to or she has it to refer to when writing her narrative. But that is for the physician to write. Most of my agencies will go in and make sure that this certification statement is put in with the right information so that the patient's name is there. And then the narrative attestation, we do write the doctor's name in here and the date that the doctor is going to be signing this. I'm going to have the doctor be signing this at IDG next week. So I'm going to put that date, and then I will save the document. Not complete. Do not complete it. The doctor needs to complete it. If this is a recertification for the first recert, everything is pretty much the same. And on the 60-day recertifications, which we'll discuss when we go over recert, you also have these specific parts about the certifying that the face-to-face encounter was completed. Where most of my clients will put the patient's name and the date of the face-to-face inside of the attestation statement so that the physician doesn't forget to do that and you have a technical denial. But as this is our first, I'm going to put in doctor's name and I'm going to save my document. Once I save it, I'm going to cancel. I go to my list view, and I'm going to reassign this to my hospice physician, who not only should be in your physician list, but should be a user so he can complete his documentation in the medical record. I happen to know this doctor is not listed, but I'm going to pretend that Mr. Matt here is the person who's going to be filling that out. You can see that I still have it on the 26th. So I'm going to go to my calendar view because I really like to drag and drop. And I'm going to put this on doctor's calendar for Monday when he comes in for IDG. So doctor will complete that documentation on that day. So once your initial initial comprehensive assessment is approved in QA, your initial plan of care will be created and everything will be good. You will also be able to see your plans, goals, and interventions in your plan of care section of your patient profile. Your patient is now in active status. You can see Barry is now here as active. You can see that we have a medication profile for him now. I can go back to my quick links and I can see that the diagnosis history, I can see the frequency, I can see the infectious disease profile, his allergy profile. All of these things I built here today on my initial assessment. On our next training, when we go over routine and PRN and recertification clinical documents, we will go over how to update the medication list, update the plan of care, update your frequencies, and to make changes to those, as well as how to do your IDG summary from your routine notes without having to go in and do them the night before or the morning of your IDG. I hope you found this to be informative. Please visit our Help Center at any time to be able to find more information about how to use the features in Axxess Hospice. And you can also go into our blogs at the Help Center to look for information related to eligibility with the LCDs and HIS management. Thank you very much and have a good day.
Thank you for joining our on-demand training today. Axxess is the only home healthcare technology company approved by the American Nurses Credentialing Center to offer continuing education credits and the most recommended home health software on Software Advice. You can watch more on-demand training videos through our industry-leading help center or at axxess.com, where you'll find tutorials, blogs, white papers, and answers to frequently asked questions. Axxess, empowering care anytime, anywhere.